In industrialized countries, age-related macular degeneration consists in the main cause of irreversible blindness in elderly people. This end-stage disease occurs in two forms: atrophic and exudative. The exudative form leads more quickly to a deeper and larger scotoma and is twice as common as atrophic form. Bilateral involvement may develop in 40% of the patients over a period of 5 years. Based on large population studies in the United States, Australia, and the Netherlands, a reasonable overall estimate of prevalence of end-stage macular degeneration is about 1% in people who are 65 to 74 years old, increasing to 5% in those who are 75 to 84, and 13% in people at 85 or older. Macular translocation seems to be able to stabilize and sometimes even improve visual acuity. However, full macular translocation bears a considerable risk of PVR, diplopia, and macular edema. Jowson and authors have described a patient with age-related macular degeneration in the form of geographic atrophy who underwent autologous translocation of retinal pigment epithelium and choroid. Vascularization of the patch was visible 6 weeks afterwards. Autofluorescence was stable throughout the follow-up. 6 months after the surgery, fixation was stable on the patch. Although far visual acuity decreased, progressive reading remained possible. Here we report the functional and anatomical outcome of peripheral autologous translocation of choroid and retinal pigment epithelium in 7 eyes with age-related macular degeneration in the atrophic form. After circular heavy diathermia in the mid-periphery at the 12 o'clock position and removal of the retina in the diathermia marks, we used vitreous scissors to cut out the full thickness patch of retinal pigment epithelium and choroid of approximately 1.5 by 2 millimeters. We then loaded the cutout patch on an aspirating spatula and repositioned the patch under the macula. Through the existing paramacular retinotomy. Seven patients with non-exudative age-related macular degeneration have been included in the study. The follow-up of these 7 patients was 2 to 8 months. Preferred fixation on the optical coherence tomography monitor was over the patch in 4 patients. The OCT images were not easy to read. The retina could be better evaluated than the retinal pigment epithelium and choroid. The retina over the patch remained thicker than usual in most patients. There appeared to be a correlation between a thinner retina and a better function. Retina detachment due to PVR developed in 2 patients. The silicone oil was removed in all 7 patients, usually 3 to 4 months after the first procedure. When removing the silicone oil, some degree of retinal puckering cellophane maculopathy was present in the patients. The described surgical method combines several desired objectives. Functioning differentiated RPE cells on their native substrate were transplanted with relatively simple technology in one-step, 1-hour surgical procedure, which was applicable to patients with a non-exudative MAD. Future development for retinal pigment epithelium reconstitution include the use of an artificial membrane as a substratum to be repopulated by retinal pigment epithelium improved in culture by gene transfer or stem cells.